So let me start with a question, simple quiz. Why doesn't this work? Wow. So how many American soldiers are killed each day in combat? So there are some proposals of numbers. The other question is how many American war veterans commit suicide each day? Please take a short moment and think, what is your guess? I will show you the answer on the following slides. So the casualties, they are horrible almost every day. There are at least 1 or 2 persons who die, if you take the average for many, many years. But what is really shocking, there's a high number of suicides. And certainly you know that this fact about the high suicide rate in veterans was one of the main reasons that the psychedelic renaissance was possible. There was a political and societal acknowledgement that this is a public health problem, and society and research should do and must do something about that. And this is one of the reasons why we are all here. So MAPS started MDMA therapy for war veterans in America. And I think it's very important to remind that we all are in this context. And to go even further, I would like to show you another public health crisis that occurred about 150 years ago, and we are also standing in the follow-up of this, what happened 150 years ago, and this was the following. So you have here a picture, quite famous, from Jean-Martin Charcot, who was a neurologist in Paris at the Salpêtrière Hospital. And the question the doctors and society at that time had about a very bizarre disease called hysteria. And nobody really know what is this about. Is this an infectious disease? Is this a neurological disease? What is happening? The women, there were thousands of women in many, many hospitals all over the places in Europe. And they had very bizarre symptoms. They had neurological paralysis. They couldn't move certain way. They had sensory problems. They had epileptic or pseudo-epileptic, as we know today, seizures. And they had, very importantly, also amnesia. They couldn't remember important facts of their lives. So that was a major public health question. What is wrong with these women? And Charcot, he was a neurologist. He investigated for years this woman. He was able to prove that neurologically, organically, there's nothing wrong with this woman. There's nothing wrong with these patients. So it was diagnosed as a functional disorder. It's not a neurological disorder. That was a very important finding of that time. And you see there were many, many ambitious men studying with Charcot and trying to make their career. And there's also an important detail on the very left side. You see there's a painting of a crisis, of an epileptic crisis, hysterical crisis, where you see this typical posture of this woman that is bent behind. We call it the bow of circular bow movement. This was the typical posture of this woman that was symptomatic for hysteria at that time. What is important to remember, now we do not see this in clinics anymore at all. But this clinical manifestation was the basic common manifestation of hysteria of that time. Today we have traumatized patients, but we have other symptoms. And Charcot, he was quite criticized for having had this painting in, because the people say, well, this woman, they're just presenting symptoms that the doctors want to see. Maybe some of this might be true. I rather believe that trauma victims, they just show the symptoms society allows them to show, and which might be acknowledged. So the most ambitious doctors of that time, they came to Paris trying to unveil the secrets of hysteria, and 2 of them I will present you furthermore. I want to ask you a question here in the people. Who ever heard about Pierre Janet? Quite some people. Who ever heard about Sigmund Freud? So, yeah. So that's important to mind. There were these 2 men that really tried to understand what is going on with these women, and they both came to the conclusion that at the bottom, the root problem of hysteria is the sexual trauma. And in most cases, it's childhood sexual trauma. And this was a very difficult conclusion for that time. And for some reason, Freud, he started to continue this hypothesis about what happens to this woman, and he was thinking, well, maybe the trauma is not real, it was just a fantasy. And maybe it's just the problem of history is the child imagines, has aggressive thoughts or urges against the parents or sexual urges towards the parents, and it's difficult to acknowledge that, and it's the child is ashamed of this, and it tries to combat and defend against these beliefs and impulses, and this creates symptoms. So he called this the Oedipus complex, and this is all the basis of what we call the theory of neuroses. So this was a scientific theory developed on the evidence of trauma, but it was a whole interpretation that was presented to the scientific community, and Freud was able, of course, to make a career with that. Of course, he had to struggle a lot, because even the idea that there are sexual urges in people was difficult to admit at that time. So I'm not here to blame Freud. Freud, he did the very best he could to bring the subject of sexuality to the broader public consciousness, but we show that the public view on what is trauma and what are sexual traumas is broadly influenced by the views of Freud until today. The other doctor, Pierre Janet, he was sticking to the idea that the trauma is real and that the trauma is just such a difficult challenge for the integrative capacities of the individual that it's just overcharged. There's a deficit of integration of what happened. This was the idea of Janet, and he built his treatment approaches on that. And today, psychotraumatologists, they are much more referring to Janet than they do to Freud. So the next slide shows you what is the essence of trauma in a drastic picture. So the trauma mainly nobody wants to talk about. We all want to go on and forget about it. Society don't want to be stuck with thoughts and problems about trauma. We all want to put a big layer of sand and, if possible, of concrete, and nobody wants to be confronted to it. But the problem is the atrocities will refuse to be buried. They will come up in symptoms, in bizarre things that happened at the individual level and also in the society. So who are these people in the blue jumpsuits? These are the patients and these are the therapists. And I can tell you, normally when a patient comes to seek treatment, he doesn't ask me, I want to see the trauma that happened to me, I want to see the monster in my basement, please can you take it out, I don't want to have it, I have it in my belly somewhere, take it out. This is the paradigm what patients ask of exorcism. They are haunted by something evil and they want that it be taken out. Like the movie Rosemary's Baby, there's some evil thing inoculated in a woman or in a human being, and it creates enormous suffering, enormous panic, and the patients come and ask, please take it out. But nobody wants really to have a look at it. So what trauma work is for the patient and for the therapist, it's very, very disagreeable, it's stressing, but it has to be done. Because if you don't do it, the symptoms will persist. But this is a difficult work, and so we all have tendency to avoid it. So patients want to avoid it because it's very painful. It's overpassing their capacities of integration, and society as well wants to really not too much look at it. And therapists, it's difficult as well for them. So if you look at the reality of trauma in our societies, there are lots of good studies done all over the world that show it's the high prevalence. So it's a real occurrences of trauma. You find numbers like 40% of young teenagers before the age of 13 have been exposed to at least one really important traumatic event, at least before the age of 13. And at about 8, 9, 10% have been exposed to sexual trauma by that time. And of course, later on, the prevalence goes up. All of us, kind of way, have been exposed to trauma, and this is part of life, of course. And we do not all have sequels of trauma because we normally are able to integrate this, luckily. I show these numbers as well because it shows that there's no difference between social classes. This is concerning all the social classes, educational classes. And what is striking that there have been lots of brilliant research papers written about this by brilliant people. This was this book from Rougemont-Bücking. I present it because it has a very nice subtitle. It's called The Hidden Epidemic. We have so many proofs of how important trauma is and how widespread and pervasive it is in our society, but we literally do not talk about it. In my opinion, we do not talk to the correct extent about it. So, what I wanted to say with these slides, society is the place where trauma occurs, interpersonal trauma, acknowledges or not the occurrence of trauma. We have seen this with the war veterans. They acknowledge to have been traumatized and society is ready to help them. But there are lots of other groups where there's no acknowledgement of their trauma. Society shapes also the clinical manifestation of trauma-related disorders. We have seen this with a picture of the woman bent to the back. Society directs research on trauma. Society allocates compensatory and/or therapeutic resources for trauma victims, for which and how, this is also a difficult subject. Shapes the popular narrative about trauma. And finally, as we saw, shapes the scientific theory about trauma. And that is why I'm really lucky to be part of the MIND movement, because when I discovered the webpage and I read this phrase, establishing the psychedelic experience as tool for personal and societal development, for me it's really, as a trauma therapist, it's evident we cannot just treat patients, we have to be aware what's going on in our society and how the society influences also our work with patients. So now I go more to the individual sphere. What are the effects of repetitive early life stress? I cannot really go on talking about the hardware problems. We certainly have known about epigenetic regulation, which is deeply altered in traumatized people from the birth on many times. And I cannot talk about the dysregulation of the stress axis. You know that these people are in constant hyperarousal. They're constantly thinking that something very threatening is happening, and they're constantly aroused, and this is happening in their stress axis. I would like to talk a little bit about the software problems we have in these patients. One I already mentioned is the phobic avoidance of the traumatic memory. They have really fear, extreme fear, to see what happened. And this is not a problem of will, it's a problem of capacity. They are not able to look there. And they have something which trauma specialists call the deficit of contextualization. I will come to this next slide. But the most difficult part of the software problems of such a patient is the traumatic attachment. They have been taught to arrange with abusive situations during long times. They have to find a way how to interact with the perpetrator. So we can know this also as the so-called Stockholm syndrome. You have, as a victim in captivity situations, you have to find out ways how to deal with the perpetrator, how to identify with the perpetrator. And this is a major problem for our patients, to later on connect with normal people. So this is a model of normal integration of a normal, healthy person. You are normally able to look wherever you want in the experiences of your life, of the past, of the present, and of the future. You're free to go where the mind wants you to bring and your interest. So you can look what happened in the past, and sometimes the past is popping up and telling you, well, now you're living this, but it's related to the past. And all this enables you to plan the future and to perceive the future as something realistic. This is a model of normal integration. If you have a traumatized person, then you have what specialists call a structural dissociation. So you do not have longer only one whole part, you have at least two parts. One of it, it's a traumatic part, which is related to the trauma of the past. Therapists call this the emotional part, the EP. But normally, what you see in daily life, it's a part that is busy with dealing with the present life. That's we call the apparently normal part. But this apparently normal part is not really normal because it's constantly dealing with keeping in balance with the emotional part. And what is important, you see there is no connection, there is no gap, a bridge between the past part, emotional part, and the present part. You cannot go through by your will, by your interest, because the border is strict, opaque. There's no transition of information between these parts. What you see is when the patient tries to go there and look there, there's this avoidance, and there's also amnestic symptom that he cannot remember. He cannot even look. It's not possible what happened. But what happened instead, these are the lightnings, the traumatic past breaks through by ways of intrusions, traumatic intrusions like nightmares, flashbacks, panic attacks. And this is so exhausting for the person to deal with this haunted house, he's living in a haunted house, that the traumatized person is not able to perceive the future and plan the future. It's just occupied in surviving in the present time. So this was conceptualized by the Dutch specialist Nienhuis and Anne van der Hart, and I think their approach is brilliant and very important contribution to for trauma therapists, and this is in direct reference to the work of Pierre Janet. So this is the summary of what they think, what is traumatic dissociation. So it involves at least two parts, sometimes more. There is no connection between the parts. And it can be understood as an attempt of adaptation to a traumatic situation. But the system is overcharged by all this. And this keeps on going on for years and a whole lifetime in many patients. And we saw that this is generating lots of symptoms. Dissociative symptoms can be negative, such as amnesia or paralysis. They can be positive, like intrusions or hearing voices, which is very frequent in these patients. It can be psychoform, hearing voice I mentioned, or somatoform. This is what we see in the clinics today with our patients. So what can we say, what is the neurological correlate of this? So we call this the deficit of contextualization. I think this is a principal dysfunctional mechanism in PTSD. So I participated in a study about that. What happens when PTSD patients do extinction learning? So they learn not to have fear in a given context. And they do learn this pretty well. So they really learn, in this context, I'm safe. But the next day they come back and they are provoked again. And they do not remember this, what they have learned the day before. So they cannot recall rightly that this fear was extinct the day before. So they have a deficit of recognizing the context and the safety of the context. And they're always activating the context of fear and of threat. This is what we call a deficit of contextualization. And we have identified the areas. It's the DACC, dorsal anterior cingulate cortex, which is hyperactive in these patients. And the VMPFC, the ventromedial prefrontal cortex, that is hypoactive in these patients. This means, from the point of view of the patient, he's never safe. Never safe. This is the reality of the patient. And if you do, in conjunction with other studies, especially in the field of addiction, you see that these two centers are dysfunctional in addictive patients and in trauma patients. And we know now that these centers, the DACC and the VMPVC, so in the animal model they call prelimbic cortex and infralimbic cortex. They are the controlling instances to control the activity of the accumbens or of the amygdala. So the fear response or the addiction response is guided and controlled by these cortical centers. And if you look, so what are the consequences of this? Is the whole pain network in these patients is dysregulated, and the reward network as well. And this explains many of the clinical symptoms of these patients. It's due to this altered activity of the two centers. So psychedelics, certainly, of course, they do also act on these two centers. So I was very lucky to find out that the VMPC was investigated with psilocybin, and we show a very clear here, it's a red spot, deactivation of the, it's part of the default mode network, and we see a very clear modification of its activation induced by psilocybin. And we can see the same from the DACC, where you can see it's also modified its activity, the connectivity after the ingestion of ayahuasca. So we can say the psychedelics, they work on these centers, but what for me is more important than is just to see what happens on the phenomenological level. Just to remind this famous quote from Gabor Mate, which I think expresses very well what is a problem of a traumatized person. He says, trauma is loss of connection and trust, which is basically the same, towards oneself and towards the world. And this is very close to the phenomenological triad of depression. I'm in pain, the world is a place of pain, and it will always be like this. And this is, if you really imagine that you were in this day after day, year after year, in this kind of feeling, you feel yourself in the world, you understand why the war veterans or other traumatized people, they commit suicide, because it's an unbearable pain. So, I have shortly mentioned three major problems, software problems in complex PTSD patients. One is the phobic avoidance of traumatic memory. The other one is the deficit of contextualization. The third one is traumatic attachment. I think that MDMA is the best agent to go over to do something about phobic avoidance of traumatic memory. That's what we see if we watch the videos from the Mithöfers. People are able to access the traumatic parts that are avoided so far. We have talked just before by my colleague. But the deficit of contextualization, I think this is the real virtue of psychedelics, that they bring in the context of now. Everything what is now, here and now, comes in the mind of the patient when treated under the effects of psychedelics. So I think it's very useful to implement this in trauma therapy. What is the most difficult part in trauma therapy is the traumatic attachment, and I think here psychotherapeutical integrity is the most important tool we have to develop and keep on developing, because it's about connection, creating connection to stable attachment in the real world, outside of the therapeutical relationship. We have to send the people out in the world, but we are afraid that the world might re-traumatize them again. So how safe is the world really? We have to care about that. The mechanisms I already mentioned are free extinction learning. Another mechanism is reconsolidation modulation. So I'm coming to the end of my talk. Just to remind this work also as well, it's a famous study already 15 years ago that shows that psychotherapy is so important, especially for traumatized people. You know, I have people with depression, but what is depression really? I think depression is just a symptom, and behind depression there are many other things hidden. But if you really have depression related to traumatic experience in life, you can see that psychotherapy is more efficacious than pharmacotherapy, and it's significant. So with pharmacotherapy, you do not do really much for these patients. They really need to be in a healing relationship, and it's very important to remind that. And if you add antidepressant to this therapy, you gain a little bit here, but it's not significant. So the most important tool for treatment for traumatized people is the relationship. So this is an overview of what I try to tell about what is trauma and how it's related to normal states of consciousness. We have seen trauma is a lack of integration and division of the personality. So we see this black border, the line here. The traumatic part is stuck in the past. Trauma isn't over yet. And we have some parts that are related to the present time. If we are a healthy subject, we can go everywhere we want. We don't have a part that is divided from us. But if we are going to complex trauma or even to DID, is dissociative identity disorder, we have lots of parts that have been under the direct influences of trauma right now. So in my opinion, what we have to take care of when we look at altered states of consciousness and we look at trauma patients is, are there parts? Check for separateness. Can we identify parts of the personality that are not related to now, that are related to the past? The also question, in an altered state of consciousness, are there parts? Is there a separation of something? This is important to identify this. We have to train ourselves to be able to identify this. In therapy, what we try to do, that is to build a bridge between these parts here, the part that is related to now and the part that is totally related to the past. This is called go for co-consciousness. Healing only occurs if there is realization of what happened. And only if realization occurs of what happened, integration is possible. And also, very importantly, integration is never finished. It's a process for all of us that will never end until we die. So this is what I wanted to talk about. Thank you so much. And I don't know if I have time for questions.
Thank you, Ansgar. We'll take 2 questions. Yes.
I want to say, can you hear me? Yeah. I really love that you really emphasize of the therapeutic relation and how important it is. I would like to ask you, what would you say, what would be the, in your opinion, minimal time of the integration therapy after the psychedelic experience?
The minimum time?
For integration therapy, thinking that the therapeutic relation is such an important part.
I think you still have to think about months or years still for these people that are stuck in traumatic bonding and they do not have, they're not connected to real life attachment. They need lots of time, months and years. Yeah.
Thank you.
Thank you. Another one? Yes, please.
I've heard that MDMA helps. That the problem is with trauma that the memory is not well ordered in hippocampus. And is it true that MDMA helps to order the memory by getting it over the cortical regions? Could you explain that?
I have no idea. I didn't
Okay.
really not informed about this kind of idea about the effects. And I think it just allows to access the difficult parts. But what happens more, then I don't know.
So thank you very much.